Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
Welcome back everyone. Today we are going to have a nice chat about a paper on hemorrhoidectomy, particularly traditional Milligan MORGAN surgery versus LigaSure. And I'll be having a chat about assumptions and introducing a series of lectures on how to run your own statistical tests. I'll leave you to it.
So thank you everyone for joining us this evening. So today we're going to be talking about a paper comparing the Milligan MORGAN technique for hemorrhoidectomies against LigaSure in Nigerian patients with symptomatic hemorrhoids. This was published in the World Journal of Surgery in 2024 and was presented by myself and Gio.
Excellent. Just a brief background, as we usually do, about the topic. Well, we do know that pretty much all of us have hemorrhoids, but sometimes they can cause a little bit of grief. When they become abnormally dilated, they can prolapse, they can bleed, they can cause discomfort. And this is probably one of the most commonly assessed complaints in general surgery, affecting anywhere between 1 in 10 to 4 in 10 in the general population in developed countries. And certainly it is a big problem in developing countries as well. This is just a diagram from the NICE guidelines. There's a number of guidelines out there on how to manage and handle hemorrhoids, from get it right first time to NICE to ACP GBI. You can just pick and choose which one you like most. And this paper particularly focuses on a technique to remove hemorrhoids that uses a particular device called LigaSure. And hopefully will shed a little bit of light, or at least help us a little bit understand whether we should be using this device or not. Ball back to Shaz for some aims.
So in terms of the aims, we're going to talk about the population, which is the attendees of a tertiary hospital in southwestern Nigeria, both male and female above the age of 18, with 3rd and 4th degree hemorrhoids, or hemorrhoids that are 1st or 2nd that were treatment resistant. The intervention we're going to be assessing is the usage of the LigaSure device, and we're going to compare that against the traditional Milligan MORGAN technique that is usually used. The outcomes are many, and we'll go into this later, but we'll be exploring the peri and post-operative complications, as well as the pain and symptoms post-operatively, also looking into blood loss, as well as the operation time itself. The presumed hypothesis we're going to take from this is that the LigaSure will have a reduced post-operative complications.
Perfect. So let's dig a little bit more about the methods. This is described as a randomized controlled trial. Now, the author used the word quasi-randomized. Having read the paper about 3 times, I still can't figure out why they call it quasi, because they simply use, well, simple randomization. At least that's how they describe it. As we mentioned, this is conducted in a tertiary center in southwest Nigeria, and the recruitment period is over a year. The study is not blinded. Patients and clinicians know what interventions they are having, and certainly it is impossible to blind the surgeon to the intervention, but assessors and patients could potentially be blinded to it. They predominantly look at resolution of symptoms at 3 and 12 weeks using a validated, well-known scoring system. They also look at post-op pain at 6, 12, 24 hours, 1, 2, and 4 weeks post-operatively. You have to bear in mind that they keep the patient in hospital for a night after the procedure. That's why they're able to determine what post-op pain scores are at those points. So they're directly measured on a VAS. They also look at blood loss, which is very accurately measured by weighing the swabs used during the operation. Ball back to Shaz for a bit more about methods.
Thank you very much. So going on to the inclusion and exclusion criteria. The inclusion criteria is anyone above the age of 18 with symptomatic 3rd and 4th degree hemorrhoids, And as we alluded to earlier, first and second degree hemorrhoids were included in a few events only if they failed conservative treatment. In terms of the exclusion criteria, anything with any pre-existing anorectal lesions, any previous anorectal surgery as well. So these were, I was going to say virgin abdomen, but virgin rectum, but that sounds even worse. Anyone with a bleeding disorder or an anticoagulant, and anyone who's immunosuppressed. And the examples they mentioned were diabetes, retroviral disease, or on steroids. Back to you, Gio.
Fantastic. So let's start looking at the results. Now, you will notice straight away that despite using simple randomization, and if you go back on our videos on randomization itself, you realize why this is weird. The two groups are exactly identical. 26 patients in the LigaSure group, 26 patients in the Milligan MORGAN group. If you look at the baseline characteristics of the patients, they're actually pretty much equally distributed across the two groups. And if you look at the age groups, for example, you kind of notice that it's not that different from what we see in our clinics. Perhaps BMI is a little bit more distributed towards normality in this cohort, but actually not as much as you would think. Ball back to you, Shaz, for a bit more results.
Thank you very much. So we'll go on to further what the actual primary and secondary outcomes were, because it's quite unclear and it seemed to mutate as the paper progressed what the true primary outcome were. So we'll list all the outcomes that they mentioned. So initially, with regards to their satisfaction rates, you can see table 1 here showing you the difference in satisfaction rates from the least option, which was indifferent, to the most, which was very satisfied. And it appears that there were more people who were very satisfied in the LigaSure component. We're not sure at what stage in the procedure, in the aftermath, this was done, because when we go on to the next table showing the actual resolution of symptoms, we see, if we're looking at the complete and partial resolution of symptoms, there was a slightly higher level of complete resolution of symptoms at 4 weeks for the Milligan MORGAN, but then, as the data suggested, at 12 weeks, there was 100% complete resolution in both parties there.
Fantastic. Now, let's get into a very relevant outcome here, which is blood loss. Now, as you can see, there is a difference between the two groups. It is, however, in the remit of 15 milliliters of blood lost. So it is statistically significant with, as you can see, a quite remarkable p-value. However, the clinical significance is arguable. I'll let you decide how relevant you think this is in the context of an operation of this type. Ball back to you, Shaz, for a bit more.
Thank you very much. And this is just to wrap up the results. So these were the final findings. So in terms of the post-operative time, we can see a very significant p-value suggesting that the LigaSure had a mean of 18 minutes and the Milligan MORGAN was 34.2 minutes. So a significant amount of time saved there. Then going on to the mean pain score, obviously the study initially alluded to the fact that it's been measured at 6, 12, 24, 1, 2, and 4 weeks. But the only data that was provided was at 6 hours, 1 week, and 2 weeks. With 6 hours, the mean pain score being 2.7 for LigaSure, 3.08 for Milligan MORGAN. At 1 week, it was 5.7 for LigaSure, 6.7 for Milligan MORGAN. And then at 4 weeks, it dropped to 4.58 for LigaSure and 5.96 for Milligan MORGAN, with the p-values attached. In terms of any complications, both arms had 1 episode of urinary retention in both of them. There were no other documented complications, and there was no fecal incontinence, which was a concern mentioned quite early on in the study. Back to you, Gio.
Excellent. So the authors are brief in highlighting the limitations of their study, and they basically mention sample size as their main limitation. And it would be possibly arguable that sample size is a matter in a randomized controlled trial if adequate sample size calculations had been performed. The authors allude to having performed sample size calculations. However, I will leave the rest of the comments on this up to Shaz, who's going to talk about the limitations that we think we picked up from this paper.
Thank you very much. So, as we've suggested, the authors themselves said the sample size was too small, but it didn't really comment on what the significance of that was. We discussed and we believe that actually, is the sample size too small to be significant? They mentioned very briefly in the study that a minimum sample size was calculated, but there's no clear methodology on how this was obtained and how they've come to this conclusion. Also, there was no clear primary outcome. So as we've suggested, there were many outcomes measured, and throughout the paper, it seems to change the priority of what that clear primary outcome was, but there seems to be no actual clear mention of what that is, which then feeds back into how the minimum sample size was obtained if there was no clear primary outcome. It's also unclear whether this is a superiority study or a non-inferiority study. One would assume it's a superiority study given that we're trialing a new, more expensive intervention, but there's no clarification by the paper. And again, this would feed into how we obtain the minimum sample size. We mentioned about the simple randomization as well. So the method that was mentioned in the paper was giving out effectively ballots to the various participants, and they would simply choose which one they would be. So we obviously Gio alluded to the fact that it mentioned quasi-randomized, but it appears to be more simple randomization. It's also unclear in terms of the statistical testing that was done and whether the multiple statistical testing could have given rise to false positives and what balances or measures were taken to calculate this out. It doesn't appear to be something that they've really looked into there. There was also no binding either way. As Joe mentioned, it's very challenging to blind the surgeon to what operation they're going to be performing, but arguably there could have been an element of potential blinding, at least attempted, for the patients to not skew their potentially subjective symptoms. We also look into the external validity of this. So with LigaSure being much more commonly used in the UK due to its availability, I think we discussed that actually in Rotherham, it's perhaps more common than it is elsewhere, but in Rotherham, where I've seen most of mine, there is a lot of that going on there. And then we also talk about the fact there being no cost analysis. So obviously we're implementing a more expensive procedure, but there's no real talk about the cost analysis. It mentions that there will be no cost to the patient and the hospital will cover the costs. That's all that's mentioned in the paper. However, though, there's no clear mention of what the actual cost implications are and how those might weigh into the decisions about which operation we should go for. Back to you, Gio, to wrap it up.
Fantastic. So in the words of the authors, we can say that the LigaSure appears, based on the result of the study, to be more effective at reducing blood loss by a whopping 15 mils and shortening operative times. But in long-term, in terms of long-term symptoms, resolution is pretty much the same. And the table here highlights a few points that we made throughout the presentation. So we're not going to go into details for that. That's all for us. Thank you for listening.
Just a quick summary about what we discussed following the presentation of the paper. The core of the discussion here related to, again, the definition of quasi-randomized controlled trial, as well as the importance of defining a clear primary outcome when designing an RCT, as without a primary outcome, it is impossible to effectively define what is the sample size population required, and ultimately what we're trying to achieve. So this is going to be the main question that we will pose to the authors when we send them a letter. We further discussed a few points that were made during the presentation, as well as delved a little bit more into the expert domain about LigaSure hemorrhoidectomy versus Milligan MORGAN hemorrhoidectomy, and how practice differs hugely between different hospitals in the UK, even within the same region. I'll leave you to the presentation.
So, as I said, this is the first of hopefully a few lectures on statistical tests. It will be very practical. And today we're going to talk about assumptions. And hopefully I'll be able to explain a bit better what assumptions are and give you an example of one very important assumption and how to test for it. A couple of disclaimers before we go ahead. First of all, I'm not a statistician, and everything I know about statistics, and running statistical tests is based on my own experience of having done things, experimented, tried, read, learned over the years, but I don't have a qualification in it. And I'm not an expert in statistical software. I've used them numerous times, and I've spoken about statistical tests before, but certainly I'm not an expert as such. So I'm sorry if there might be some hiccups every now and again, but again, everything I've learned about those stats and those software is just because of trial and error and reading and learning. So let's start with a few important things about statistical tests. Well, whenever we start working on a project and we are collecting our data, the first thing we start thinking at is, I'm going to run some tests and I'm going to get a p-value. Now, that's all very nice. And certainly this is the way I felt when I started working on my first research project back in med school. But what I didn't realize is how, well, first of all, it's not exactly easy. And secondly, you kind of need to know how to handle your data and what type of data you're dealing with. I'm not going to go into details about how we classify data and how we describe data. We've run a number of sessions. Chapters 13 to 15 particularly deal with descriptive statistics. Which one should you choose? Tables and the special tables and charts. And I'd encourage you all to have a look at them because they explain in details how to classify data and how to handle it in the first instance. Probably the most important things to remember for the purposes of this presentation is data can be divided in categorical data and a sort of measurement scale data, as Prof kind of split it when he presented it before. And today we're going to focus on quantitative data particularly. And as this chart demonstrates, when you are approaching your data, the first thing you should ask yourself before running any tests or using any descriptive statistic is, what type of data have I got in front of me? And today we are going to focus on continuous, and we are going to try and identify why it is important to know whether your continuous data is normally or not normally distributed, also known as skewed. To do this, we are going to use a piece of statistical software that I particularly like, which is open source and freely available. You can scan that QR code and have a look at it. It is very simple to use. It's basically a statistical spreadsheet, very similar to SPSS, but it is entirely free and open. And it is basically built on R, is very well integrated with R, which is probably the most powerful and the most well-known free statistical software available. You'd argue statistical software in general, but the Jamovi interface just makes it so much easier to use. Now, without taking any more time, we said we were going to talk about assumptions. So assumptions are talked about a lot in surgery and in TV shows. Certainly, whenever we're dealing with a patient that's a bit difficult, we always say assumptions are the mother of all evil, or all F-ups, if you like. And certainly, as Jack Richard would say, assumptions in an investigations do kill. And ultimately, when you're running your own research project, you're effectively running an investigation. So whenever you are running a test, you're effectively making an assumption. And that assumption has to do with the data you've got,
such as its type, distribution, and so on. So ultimately, an assumption is a truth about your data that has to be fulfilled in order for the test that you're running to be valid. If you get that wrong, you might well get a result, a numerical one, such as a p-value, but that p-value might well be meaningless if the assumptions that are specifically relevant to that test are not fulfilled or true. So today we are going to focus on one of the most important assumptions in statistics, and this has to do with continuous data particularly. And as you can see in this diagram, the first split you meet when you go down the path of continuous data is normally distributed versus skewed.
The main assumptions you're making when you're running a test is that your data has a particular type of distribution, at least a continuous data. A normal distribution is, as you can see depicted in this image, a distribution where the data is kind of clustered around a middle point. That middle point can be any number, really, but as long as the data is equally spread on the right side and on the left side of that middle point, your distribution will be normal. In an absolutely normal distribution, a classic one, the vast majority of the data will lie within 2 standard deviations from the mean, as you can see in this diagram. Within 3 standard deviations, nearly 100% of the data will be contained. This is, as you can guess, very different from a skewed distribution. So how do you know if your data is normal? How do you know if your data looks like this? Well, first of all, you can look at the data. So you can just look at the numbers as they are, and you can look at the average value, the mean value, and you can look at the median value and determine whether they're vastly different. You can look at a number of different types of indicator of how the data is distributed, just numerically, and determine whether it is likely to be normal or not. You can really look at the data and just ask a piece of software to build you a histogram, and the histogram will either be symmetrical, like the one in the middle, and then you will know that your distribution is likely to be normal, or it will be skewed. It can be positively or negatively skewed, depending on where the median, the mean, and the mode end up lying. And I'm not going to go into details about this because, again, we spoke about this before. This is just sort of a little bit of a refresher. And finally, if you really, really need to demonstrate that your data is normally distributed, you can also run a test for normality. And this is what we're going to focus on in the next couple of minutes. The classically used test for normality is called Saphir-Wilk test. It's been described many years ago. I believe it was a couple of years before I was born, actually, when it was described first. I won't tell you what year that is. And the assumption, well, this test, null's hypothesis is that the sample belongs to a normally distributed population, aka if I run the Saphir-Wilk test on my data and the p-value is statistically significant, it means that my distribution, the distribution I'm dealing with, is not normal. That's plain and simple. Now, how do you do it? Well, as I said, we were going to have a go at this using Jamovi. So this is what we're going to do next. I'm quickly going to stop share. First of all, do you have any questions so far? I'll take that as a no. So, this is a data set of quite a few data points that I used for my dissertation. My dissertation was about papers and when people put them on Twitter, how well they are received and how many retweets they get, how many quotes they get, and likes, etc., etc. And as you can see, there's a bunch of variables here. Some of these variables are nominal, some of these variables are ordinal, and some of these variables are continuous. For example, retweet, quotes, and likes. Now, I needed to know if particularly the retweet variable was normally distributed or not, because I was going to run a few tests on that particular variable. So I used my lovely statistical software, Jamovi, to do it. So once you populate your spreadsheet, obviously depending on what project you're doing, there'll be different data. You can go on analysis and start by simply doing exploration and ask for some descriptive statistics. We said we were interested in retweets. So we just put retweets into variables. And as you can see, Jamovi will already give us a little bit of data here. It will tell us how many observations we've got in there, 775, how many empty cells we've got, mean value, median value, standard deviation, minimum and maximum. And you can ask for more. You can ask for interquartile range. You can ask for variance. You can ask for loads of things. Now, as you notice immediately, mean and median are vastly different. Vastly different. What does that tell us? Well, that tells us that probably this data is not normally distributed. And this is what I meant when I said, well, look at the data. Look at how it is. I can already tell you this is not normally distributed. But I want now to have a visual confirmation of this. Very simple to get it. You just go in this bottom section of the exploration panel, and you can click histogram. And as you can see, this is definitely not normally distributed. The vast majority of the data is here, but it's spread all the way out there. If you want, you could even use a bar plot. That tells you the same thing. Look, all the data is here at the bottom. Vast majority of the data is here at the bottom. Okay. And finally, if I really want a p-value confirmation that this data is not normally distributed, I just tap Sapir-Whorf test here. And as you can see, the p-value is less than 0.01. Demonstrating again that the data I'm analyzing is not normally distributed. Now, this has massive implications in terms of what type of statistical tests you run afterwards. So if I want to run a test on this data, I should use a non-parametric test. Parametric tests are used for normally distributed data. Non-parametric tests are used for non-normally distributed data. And so far, this is all we're going to talk about. Next time, we're going to start going into some more details about specific types of statistical tests. We spoke before about chi-square, so we're probably going to talk about student T, and then we'll move on from there. And
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.